This is Dr. Yu Kim Teng from the Philippines.
Okay. So we have a 71-year-old female who was diagnosed with squamous cell cancer of the esophagus, and it more or less encompassed about 70% of circumference from level 29 to 33 from the incisors, and on EUS this is a T2N1 lesion, T2N plus on EUS. Now this is a Lugol stain of the initial lesion, and then also positive silver stain. So what happened next was this patient had a neoadjuvant radiochemotherapy in 2016, and well, on follow-up, we see a lesion that is distal to the previous resection lesion. So we have a video here that in NBI that shows more or less normal esophageal epithelium, and then we have this lesion that is 2A plus C. So we have it's reddish with slightly raised and depressed center. And again, Lugol staining, which just highlights this particular lesion. We were planning to resect this lesion, so we tried to do lifting sign. So we tried to suck with the cap, and eventually we did do injection, submucosal injection, to see if it would lift. So this one I would not try to describe, but yeah, I think Professor Inoue, if you would help us describe this lesion for it.
Wow, this is very difficult. Of course, the original tumor was T2, and then the patient receives the neoadjuvant chemoradiotherapy, and then this is the current situation. Now we can say the pointer. Can I have? So now we can say that this is a background mucosa. This is the non-neoplastic IPCLs, and then non-neoplastic IPCLs coming close to the tumor. This is the exposed area of the tumor, but this part is the tumor is going behind the epithelium. It looks like a subepithelial spreading tumor. So infiltrating depths of this region is very difficult to evaluate, but superficially we don't find the very enlarged vessels. So, so this kind of a subepithelial tumor-like lesion is the we suspect a submucosal cancer.
Okay.
But not like a T2. So of course I don't know the previous lesion before treatment, but at this moment this region is the submucosal invasive lesion. That's information we can get from this endoscopy.
Okay. So we did prepare another image with Lugol. Does it give us more information that we already know?
Yeah. So this is the same thing. We can recognize the maybe original tumor shrink a lot, and then background mucosa is coming close to the surface. But anyway, so there is a submucosal lesion here. That is information. But you did very well the mucosal lifting of this region. So anyway, curative or not curative is another discussion. But we can resect this tumor, as you mentioned.
Okay. So basically, we did do an ESD, of this lesion. And yeah, we would like to request our pathology friends to help us out with
This is the ESD. You saw it before. It's about 18 to 40 millimeters. It's 36 to 40 centimeters from the alignment. And in the overview, you see normal mucosa, green colored, and then the mucosa shows erosion in this area. And at higher magnification, you can see the infiltration of a squamous cell carcinoma with some keratin pearls invading the muscularis mucosa. But in other sections of the histology, you can see that the muscularis mucosa is splitted and penetrated from these epithelial cells and invading the submucosal layer. Better colored with these double immunostaining. Brown colored are the epithelial cells, and in red is the muscularis mucosa with jasmine colored. So you can see very nice the splitting of the muscularis mucosa, the penetration of the epithelial cells with the infiltration of a submucosal layer. And focally, there is infiltration of the deep vertical margin, also in the other picture. So we could also find some little invasion in lymphatic vessels. The diagnosis is ESD from the esophagus with a moderately differentiated squamous cell carcinoma infiltrating at least the upper part of the submucosa and focally infiltrating the vertical margin. Lymphovascular invasion is there. So the TNM is PT1B, L1, V0, PN0, R1. The vertical margin is positive, G2.
Thank you very much. I have to clarify again. So this second lesion did not appear in the area of the previous tumor. It is metachroneus cancer distally to the previous radiation area, and we think that this area was not 100% radiated. So this is now for the further therapeutic strategy the question. How to treat this patient. At the moment, there is another radiation with previous marking planned in order to keep the local situation under control.
I misunderstood. So the lesion observed is not a primary lesion?
No, it's more distal.
So this is the typical findings of the intramural metastasis, everybody knows. So intramural metastasis is, of course, the cancer cell, the spread, the lymphatic network, and then some region. So it looks like a subepithelial tumor. So this is the one of the bad prognostic sign. So. Treatment option is very difficult in this case. Of course, wide area radiation. Of course, surgical resection is one of the choice. But even though we have to talk to the patient family, the prognosis is not so good.
Okay, thank you very much.